All right, welcome to this explainer. I am absolutely thrilled you're here. Look, today our mission is laser focused on you, the emergency physicians and advanced practice providers holding the line out there. We're going to dismantle a really stubborn, honestly outdated dogma regarding acute abdominal pain management in the ED. And we're going to do it by diving into the absolute latest 2025 guidelines. We'll explore exactly how we should be selecting analgesics based on diagnosis, turning all those clunky protocols into a streamlined, highly focused clinical pathway.
Okay, let's jump right into our roadmap. First, we'll talk about why the old dogma is dead. Then we'll review the 2025 guidelines, unpack our multimodal arsenal, run through an acute appendicitis case, lock down our key home messages, and finally, look at the essential references.
Section 1. The old dogma is dead. So we have to call out the elephant in the room right away. For literally decades, this old dogma taught us that we had to withhold analgesia because we'd somehow mask the diagnosis, right? It basically forced patients to just suffer while waiting around for a definitive surgical consult. Well, current evidence has completely flipped that on its head. The literature is totally clear now. Early analgesia actually improves exam accuracy. Think about it. A patient who isn't writhing in sheer agony can actually cooperate with your physical exam. Giving them pain relief does not, I repeat, does not increase the risk of diagnostic errors. It's a game changer.
And we've got fresh, real-world validation for this too. Check out this 2025 study from the Al Hilla Teaching Hospital ED in Iraq. They looked at 100 patients coming in with acute abdominal pain, and an overwhelming 90.7%, so basically 9 out of 10, received early multimodal analgesia. And what happened? Their pain safely subsided without compromising diagnostic accuracy or delaying any necessary surgeries. It's just a powerful modern testament that giving timely analgesics in the ED isn't just safe, it's objectively superior care.
Section 2. 2025 Pain Management Guidelines. Even with all this great evidence, we're still running into a massive roadblock, and that's oligoanalgesia, basically undertreating pain. Even when severe pain is clearly documented on the chart, a staggering percentage of patients still don't get prompt relief. The 2025 USEM guidelines point out that in one study, only 14% of ED patients with moderate to severe pain actually got analgesics. 14%! That's wild. We absolutely have to close this gap. We know the barriers: ED overcrowding, fear of opioid dependence, or just a lack of clear protocols. But we can't let them leave our patients in unacceptable distress.
And here's the so what of it all. Uncontrolled acute pain isn't just a psychological thing. It triggers a full-blown multisystemic crisis. As the EUSEM guidelines map out, when you leave pain uncontrolled, you get this massive catecholamine dump. That drives tachycardia and hypertension, which spikes myocardial oxygen demand. Plus, it ramps up the inflammatory cascade, actually delaying wound healing. It'll even induce hyperglycemia in about a third of diabetic patients. Managing pain isn't just about comfort, it's literally managing the patient's physiological stability.
Okay, so what's the actual standard we should be hitting? The Royal College of Emergency Medicine, or RCEM, lays out a critical timeline that visualizes the urgency here perfectly. 0 minutes, the patient hits the door. Under 15 minutes, you're administering analgesia for moderate to severe pain. Under 30 minutes, you're back in the room reevaluating if it actually worked. Boom. This timeline leaves absolutely zero room for the old wait-and-see mindset.
Section 3. The Multimodal Analgesic Arsenal.
Let's talk drugs. Everything starts with a foundational, mechanism-based approach that leans heavily on non-opioids. You want routine administration of IV paracetamol or acetaminophen because its opioid-sparing properties are fantastic. Right alongside that, you should be dropping IV NSAIDs like ketorolac early and often, assuming, of course, they don't have renal failure or severe bleeding risks. And look, don't forget the non-pharmacological therapies. Maximize those alongside your meds so you're hitting the pain from every possible angle.
Now, what about severe pain, where opioids are a no-go or just aren't cutting it? Well, the American College of Emergency Physicians officially supports an amazing tool for this: subdissociative dose ketamine, or SDK. ACEP backs SDK as a highly effective, incredibly safe alternative, or even an adjunct to opioids in the ED. So practically speaking, how do we use this at the bedside? The SDK protocol is specific. Dose it right at 0.1 to 0.3 milligrams per kilogram IV. And this is crucial. You have to push it slowly, ideally over 15 minutes. Why? Because that avoids those nasty psychoperceptual side effects.
When you dose it like this, its pain-relieving power is basically equivalent to IV morphine, but with a massive safety advantage. You entirely avoid the respiratory depression and hemodynamic instability that opioids usually bring to the party.
Section 4. Case focus. Acute appendicitis.
Let's make this concrete and track it through 3 clinical phases for appendicitis. Step 1, pre-op. Jump on pain control immediately. Morphine at 0.1 milligram per kilogram IV up to a max of 10 mg, stacked with your basic analgesics like paracetamol. Step 2, intra-op. If they're doing a lap appy, the approach should include intraperitoneal local anesthetic installation. And step 3, post-op. Keep that foundation of NSAIDs and paracetamol going strong, strictly reserving opioids as a rescue med for breakthrough pain only. That's what seamless, evidence-based care looks like, from the triage desk straight through to recovery.
Section 5. Key home messages. If there's one overarching theme from the latest 2025 USIM recommendations, it's that flexibility and patient-centric care have to come first. We've got to tailor our multimodal strategies to the actual person in front of us, making sure we don't let rigid protocols leave vulnerable patients suffering.
Okay, let's distill this down to the core clinical takeaways. Number 1, never, ever withhold analgesics because you're scared of masking an abdominal diagnosis. That dogma is completely dead. Number 2, get a multimodal, mechanism-based plan rolling the second that patient arrives. 3, make IV paracetamol and NSAIDs your absolute bedrock. And finally, save the opioids for the severe stuff and definitely don't sleep on subdissociative dose ketamine. It's a phenomenal, safe alternative.
Section 6. Essential bibliographic references. For those who really want to dig into the data, here is your reading list. These are the exact texts from the EUSEM 2025 update to ACP's SDK policy to the incredibly relevant 2025 all-size study that are driving this paradigm shift. These documents give you the clinical cover to treat pain aggressively and safely.
So, as we wrap up this explainer, I've got to ask you, what is your own ED's median time to analgesia? Are you guys actually hitting that 15-minute mark? Think about how you can take this evidence back to your shop and champion this shift. Let's make sure no patient suffers unnecessarily on our watch. Thanks so much for joining me, and keep fighting the good fight on the front lines.